Today on Surfing the NASH Tsunami.
Can you identify one novel, surprising, or unusually important point or issue that this morning led you to think about a little differently?
Well, I don't know that anything I really heard was completely surprising, but a few key points really crystallized and made me think and reflect on things with more rigor.
This weekend, over 200 NASH stakeholders have gathered in Deer Valley, Utah for the 5th NASH-TAG meeting. Join liver wellness advocate Louise Campbell, Global Liver Institute President and CEO Donna Cryer, and pricing and forecasting guru Roger Green, along with our guest surfers Dr. Manal Abdelmalek of Duke University and Dr. Ian Rowe of the University of Leeds, UK, as they identify and debate major questions from NASH-TAG Session 1, all from their own unique perspectives, on the Surfing the NASH Tsunami podcast.
For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 2, Episode 11, Session 1 of NASH-TAG 2021 starts now. We are 4 hours into the Hybrid NASH 2021 meeting, and already my head has been spinning. First of all, watching a meeting on hybrid video watching a meeting on video, a virtual meeting, feels detached. But when people are mostly presenting data, it's easier to absorb. Here, which is not about discrete presentations. Well, there are discrete presentations, but it's about stringing them together and getting the meaning out of them. That gets challenging. And when some people are in the room and others are not, that gets challenging. And just for kicks this morning, a couple of folks had challenges with their slides, and that made it, that's about all I want to talk about, challenging. So one example that came to mind, right at the beginning, during the first talk, Michael Charlton talked about the impact of the specific kind of diet a patient has on placebo response. 3 hours later, as if this is how the world works, Vlad Ratziu talks about microbiome issues in the different kinds of mouse models that we use in clinical trial. So two very different takes on diet, and I'm sure there are connections there, but I'll spend the next couple hours pondering what they are. And that's not the only time that happened to me this morning. I felt the entire morning ran that way. So first, let me remind you who's joining us for this session as compared to the later ones. Manal Abdelmalek is here, and Ian Rowe, and Donna Cryer, and of course Louise. Manal is actually in Utah. The rest of us are remote. And Manal, let me start by congratulating you for your superb presentation on lanifibranor this morning, and for wrestling with the slides without flustering.
Oh, thank you. I think they were on auto advance, even though I wasn't ready for the advance, but managed to get through it. But thank you, Roger.
Well, I thought it was great. I actually emerged with a better appreciation of why people like lanifibranor than I went in with, so that was a good thing. So second, let me describe the flow of what we're going to do today. Unlike EASL or OSL, where we simply take a few presentations we think are interesting and review them in detail, we want to make this a little bit more like how this meeting works. So I'm going to ask everybody to comment in turn on something that you found novel or surprising, or that we've really got to drill into deeper after we leave here. And then we'll take a few minutes to discuss that as a group, and then we'll move on to the next person's comment. Since we come from divergent points of view, I think it'll be interesting to see the issues that we raise. And with that, I'm not going to do the typical icebreaker because we've got 5 sessions over 3 days. So I want to mix it up, and I want to ask a very different question. It's been written in the U.S. publication several times in recent days that it's starting to seem that people are acting as if the clouds are lifting on the pandemic. So I want to know if you've seen any sign of that in your life in the last week? If so, what it is? And if not, what do you think is holding people in your environment or in your country back? Where do you want to go first?
I'll go first today. I mean, the clouds have definitely lifted a bit around our house because our children have gone back to school with all of their friends, which has made a massive difference to them, and I think to the sort of the healthiness of their household. I still think that society is, at least in the UK, is following the lockdown rules pretty closely, despite now quite high levels of vaccination in people over the age of 60. So I guess as that goes into younger people, that's probably when we'll see people beginning to ease off sooner than perhaps our government might like.
Okay, so why don't we stay in the UK for a sec, Louise? What do you think?
No, I can definitely agree with Ian on sending the kids back to school, so that's a good one, and they're excited with that, which is great. And I think also, slightly on the same point, just watching people coming into the Excel, because they hear on social media wrongly. It's gone out wrongly that we're now doing the 20-year-olds plus. But what is encouraging is they are turning up. Even if we turn them away, we are seeing a younger demographic at the moment wanting the vaccinations. And that would be normally the demographic that we would not be expecting to be so engaged because they feel immortal and they're not greatly affected. So I think that's encouraging for when we do roll it out.
And then for our listeners in the States, before the rest of us answer, let me note that Manal lives in a purple state with a Democratic governor, and Donna and I live in clearly blue territories. So you're not going to hear any comments, although I'm here this week, about Texas or Mississippi or any of the states that have unmasked, as it were. Actually, I may talk about Texas a little bit. I take that back.
I'm happy to just take a sort of a national perspective apart from what's happening in the District of Columbia itself. I think that people are longing for freedom and liberation, rightly so after a year, but it feels to me premature. Only 10 to 11% of the U.S. population has been vaccinated at this point. To reopen too quickly, I think would ultimately set us back, and we'll find out in a few weeks. I think that there's definitely hope, but from the perspective of liver patients, of transplant recipients, of renal patients, of high risk people living with chronic diseases across several states, we are beyond frustrated. We feel devalued. We feel like we've been told that we're not essential. We're not important. Our lives don't really matter, and reaching us is just not important. And so that is quite hard to deal with. And so that will spark further conversations about what it means to be a contributing member of society with a disability, and painting the different narrative of those of us who live with chronic or serious illnesses, but are still very much a part of the fabric of our families and neighborhoods and economy.
That sounds remarkably tough to live in. And I take your point.
I like Ian, I'm starting to see the kids are going to be going back to school. It's a little bit liberating in some regard. And we're starting to deploy more essential workers back into the workplace as our frontline workers and support staff has gotten vaccinated. But, speaking from personal experience today, to the point of liberation, it's been 14 months since I've seen my professional colleagues face to face. And that element, while we've done amazing things on virtual platforms, this element of personal engagement. Now, granted, everybody here has been vaccinated and we're still keeping social distancing and masking, but it brings to light the element of human engagement, human connection, human discussion face to face that can't otherwise be captured on virtual platforms, and the ability to debate, the ability to innovate, the ability to discover. While it has not significantly stagnated, I am very encouraged is going to be coming back into more vigor in the upcoming months to year.
I think that's a great point. And those of us on this call who are not there are to a person jealous that our vaccine statuses at least personal or national vaccine statuses didn't let us get there. Donna and I had this conversation 2 days ago. First, the comment on Texas. I've been here for 3 days. What I've noticed is that virtually everywhere I don't go very many places. And if I do, they're big box stores, and they're big box stores that don't tend to be frequented by folks who open carry. Let's just leave it at that. Folks have still been observing rules. They've still been masked. They've still been distanced. They've been okay. So I think in fact, the day after Abbott made the announcement, H-E-B, which is the major locally based supermarket, announced that they were going to maintain. And then a day later, they said no, they were going to make it optional. And then a day after that, they got letters from thousands of their employees saying, protect us. So it's not quite as simple, much to my delight since I'm here anyway. It's not quite as simple as Abbott puts out a mandate and immediately the state goes crazy. On the other hand, there are 40,000 tickets sold for the Texas Rangers home opener. And that sounds like the super spreader event of all time, given that Texas is the second lowest state in the U.S. in vaccination right now. My broader thought was that I'm watching people start to make plans to do things in the summer, and a big part of the problem has been you had no clue not only what normal was going to look like, but when you were even going to get to dip more than one toe in the water of normal. And as I see people start to plan to do things in the summer that they've been noticeably unwilling to do for the last 16 months, to me, that feels like the sprouting of a little bit of hope. Now, hopefully that will continue and won't get set aside by things like all the states that did away with their mask mandates. And Donna, from a very different angle, the metro Philly suburbs are way behind everybody else in Pennsylvania in terms of vaccinations per 1,000 people, for no reason anybody can say. But so I'm hearing friends of mine who live in other parts of the state who are 20 years younger than me, who can choose when and where they want to get vaccinated, and we can't find my wife a vaccine for love or money. It's not the same thing in that it's not that we're being diminished, except by where we live, but you always wonder, what the heck is that about? Or are we being diminished? Is it just one of these political calculations people had about who gets what first. You just don't know.
Well, any system that needs multiple grad students with, 3 devices each to get online at 8:59 on specific mornings to help seniors or others, find an appointment is a broken system.
Agreed. So with that, why don't we move on to the conference? Because we could do this one for the next hour, but I don't think that's what people are listening for us to do. I do want to do an episode on lessons from all this at some point in the spring, but not today.
Now, let's talk about NASH-TAG.
Manal, as I say, you own the seat of honor, first because you're in Utah, second because you presented this morning, and third because you are an esteemed professor at Duke and really a leading light. So I'd like to ask you 3 questions that kind of go together. Give us an answer, then we'll all kick it around for a little bit. Can you identify one novel, surprising, or unusually important point or issue that this morning led you to think about a little differently? And then what did you hear this morning that led you to think about it a little differently? And what might you take away about doing differently or looking at things differently as a result?
Well, I don't know that anything I really heard was completely surprising, but a few key points really crystallized and made me think and reflect on things with more rigor. Vlad, Ratziu, and Rinella did just a fabulous job crystallizing the challenges in non-cirrhotic and cirrhotic trials. And clearly we are going about this the wrong way. Our past failures we have not fully embraced in a critical enough way that we can learn and relaunch ourselves in a different trajectory, particularly as we consider histologic endpoints. And it's very clear that this ordinal approach to assessing changes in histology is misguided, particularly when we're dealing with significant hepatic fibrosis, F2 stage or higher, and it's not linear. Rinella painted beautifully that it's almost logarithmic, and the nuance of change that even happens within the spectrum of F4 fibrosis is steep enough that one cannot anticipate over the duration of time that we've been conducting trials, which is on average, anywhere between 12 to 18 months, to see a 1-stage reduction in fibrosis. And the nuances by which the biology of the disease may change, we have not been able to drill down deep enough to capture that in measurable surrogate endpoints that will allow us to really evaluate these therapeutics in a manner that's meaningful, and made me reflect on the nuances of how we've approached things as opposed to the therapies we've used in the capacity of treatment. And I think we really need to rethink this and drill down to the nuances of change in biology that is happening just beyond a fibrosis stage, and develop enough sensitive surrogate endpoints that we can measure that and be able to articulate it with confidence to regulatory authorities. The discussion also about the microbiome, how we translate animal studies into human studies, the capitulation of the variances between microbiota in animals and even in humans, and how that even changes in a lab setting versus a wild type manner, raises even further some of the hurdles, because we may not be able to capitulate all the confounding variables as we do global trials, phase 3 trials, because clearly the microbiota, even in humans, let alone culturally diverse and regionally different aspects of the world and their diet, are going to serve as confounders. And I believe more strongly that our studies that we have embarked on are likely all underpowered, not having taken into consideration this vast heterogeneity, which we can't certainly control for.
I heard 3 issues there. Number one, the issue around the nonlinearity, virtually logarithmic progression of the disease. Then second, there's a question about, are we enabling the right processes or valuing the right processes? And third, all the questions around microbiome and microbiota. 3 different issues, I think all important, and a great example of why my head was hurting 2.5 hours into this meeting as they were all running around in there. Ian, why don't you go ahead?
This discussion about why trials haven't succeeded is a really critical one, and trying to understand what it is that we can do better now is crucial. And some of that comes down to how we think about what treatment's actually going to look like on the day that a drug is licensed. Now, I don't know that any of us really want treatment that's going to be based on a biopsy for treatment entry, or goodness gracious, not a biopsy to understand treatment response and continuation of therapy. And having trials that use that model and non-invasive biomarkers that don't match. So I don't know that I can diagnose NASH reliably without a biopsy, yet, I'm saying that I want to have a treatment I can use for patients who I think have probably got NASH, and not knowing whether the treatment efficacy for those patients is really going to be the same in the field is a big problem. And one of the themes that came up a couple of times was about a more personalized approach, better phenotyping patients to understand what therapeutic it is that might work for them. And taking that, I wondered whether, Manal, you're quite close to some of these studies, how you would think about designing studies like that retained a broad label, that retained applicability to, the majority of patients who we're seeing who've got significant liver disease.
Yeah, we've talked about the nuances of study design over the years, and Mike Charlton really drove home an important point. We may not be able to control all the nuances, but maybe we can filter out some of the noise. The super responders, if you will, those that can effectively achieve diet and exercise and potentially are playing a role in heightened placebo response rates. We've talked about lead-in phases to studies. I'm not sure we've effectively put them into implementation across larger trials. That will certainly help us minimize the 60% of patients who would effectively respond to a treatment, even diet and exercise, and weed out those early responders that may not need such pharmacologic therapies and really renormalize the point of entry and delay a randomization point after a lead-in. I think that's key and a point well taken that we should think about. That was one point that I think was well taken.
This issue about the placebo response and the lead-in is really interesting. And his sort of discussion of patients that get recruited into the placebo group, there's a significant proportion of them who are, he compared them to Babe Ruth, already able to hit the sort of, your standard of care diet weight loss measures out of the park, induce significant weight loss. And I don't know that I can see that in the trials when they're published with, an average weight change of 0 and an HbA1c change of 0 in the placebo groups. And I think it'll be interesting. I have to say that I'm not convinced that will have a meaningful impact on understanding benefits to treatment. And you'd have to wonder, what's been happening in routine practice up to the point that the patient entered the trial, that those Babe Ruth figures could suddenly hit it out of the park when they'd been not reaching base for, the past 10 years.
Understanding Babe Ruth as an American icon, I think the metaphor was used differently, which is that we are the pitchers. Babe Ruth is the batter. Actually, NASH is the batter. And what we were trying to do is figure out how to strike NASH out. And NASH keeps hitting balls out of the park and defeating us. And his point was that if you take into account the factors that you can control for that we're not controlling for, in essence, just don't, find a way to take that whole diet issue out of play, then in fact, if you simply reduce the variability in the placebo group, that would have huge impact. And I believe his Babe Ruth metaphor was more about asking, can we do that if we do a better job either of diet matching or diet management, or even make sure that all the trials have the same protocols for diet, exercise, non-pharmacological interventions in the placebo groups? Because if you're seeing differences of 32 and 12, somehow those instructions, if those instructions are identical once, that's bad luck. If you start seeing that kind of variability pop up again and again, somehow we're not instructing the trials properly. So that was what I took him to be saying. If you guys heard it differently, tell me.
Yeah, it's that fine balance about introducing an intervention in and of itself by normalizing and standardizing dietary approaches, which may actually not be real world when you talk about the general population at risk. And the Liver Forum has gathered both regulatory agents, academics, and industry to debate and deliberate this point in standardizing a standard of care. And it was very hard given all the nuances and variables and the challenge of not rendering a different and new intervention that may not otherwise exist had that patient not otherwise been participating in a clinical trial that rendered that intervention. One could argue, however, we should be rendering that intervention anyway for all patients with NAFLD and NASH, so it may be irrelevant, but clearly we still have work to do.
I think that the final point is that if you look at the placebo response and try and break it down, as we've done, and we presented some data at the liver meeting, the digital meeting in last November, data that's now submitted, the vast majority of it is due to sampling variability with the biopsy. And I don't know that you can get much better than a 20% apparent placebo response when you use histology with ordinal stages as your outcome. It'll always be around there, and there'll be variation in that. And some of the trials do outlie, and I think the semaglutide study is a good example of a trial that shows a sort of supra-sampling variability response rate for whatever reason. Probably, I think, because the placebo arm, as judged by the low ELF and the low liver stiffness measurements at entry compared to the other groups, they had a relative excess of people whose biopsies had been overstaged in the first place. I think that probably explains it. And a lot of the interventions that we've talked about, standardizing other interventions, whilst I think they'll be useful, until we move away from biopsy, I don't think we'll get past it.
I'm happy to pick up on Ian's last point, because my initial notes were about the importance of non-invasive diagnostics and having the ability to have repeat testing along the way to be able to measure treatment response and progress or lack of progress is so important, since we are still so uncertain about the direction that the disease can take in any particular individual or patient profile. So just underscoring the point about we can't rely on biopsy, because you're not going to be able to biopsy people multiple times to get the information that you need. The bigger the point, and where Manal started, that stood out for me, was I really appreciate the humility of this very learned and august group who've invested so much in this field and in these trials and research to take a step back and really ask basic questions. So Brent asked, what defines NASH? So rethinking that. Vlad asked a version of, which effects matter. At the end of the day in the discussion, as they were talking more about, sort of FDA's perspective on this, they started to have a discussion, which I really interpreted as, what does safety mean for the NASH patient, or, for a patient who already has underlying, what does liver injury or DILI mean for, a patient who already has, liver disease and whose complications, might already occur even in the absence of a trial or intervention. So the ability and willingness to step back and ask these questions, in addition to things like trial size, what is the right size of a trial, continues my confidence in the field and in this research. Although, I remember a comment, and I won't directly attribute, but, a staffer at a medical society, when I was asking for more patient engagement in the work, came back and responded that, well, patients would be too upset to know that their doctors disagreed about things. And I have always felt the opposite, and it was refreshed again today, that hearing thoughtful exploration of the issues and the admission that there is so much complexity and the engagement and back and forth and pushback to find the right answers and to revisit even answers we thought we had actually provides more confidence in the field from the patient perspective, I feel. So I really loved and appreciated this morning's discussion.
Donna, that's a really important point. And one of the elements of the NASH-TAG meeting that I really loved is this first session on the pro and con debate, the point counterpoint exchange. As leaders, as experts in industry, we have to be comfortable with agreeing to disagree, and point counterpoint and dissecting out data for what it really is, and seeing the nuances of what's real and what's not real, and regrouping and reassessing. And I think it keeps us whole, because we can look at data from a lot of different perspectives, and certainly the FDA is deliberating the safety to efficacy margins, let alone the long-term impact of what comorbidities will or won't look like after years of use of any compound. What I loved about this morning's session is it was in a comfort zone where you could point, counterpoint, dissect out the data, call out what is or isn't a spade, and regroup and reassess and look at things in a different framework. I really enjoyed that session.
So, Manal, I also wanted to know that I took notes on a phrase that you used, anticipatory education, because as the Global Liver Institute is planning a patient-focused drug development meeting, which of course we'll call on you to involve you, it made me think, and I kept a very long list of the different factors and side effects that are at play here, the balance of cardiovascular risk and hepatic risk, and all of this happening in a disease that until very late stages is often silent. And as I think through how to elicit from patients what their willingness for different trade-offs would be, if weight gain is a non-starter for them versus itching where everybody says is, manageable, or communicating why elevation of triglycerides might be something that you would want to worry about. And so really understanding all the potential factors when Rohit was talking about, eczema and hair loss, I was like, whoa, those are things that we hadn't thought about. So constructing, surveys to get patient input into what factors matter to them, what outcomes matter. There does need to be an education process on what factors are even at play. And so your idea of, anticipatory education, I think is very important as we partner with the researchers and clinicians to develop the field.
And I think that's so important even for the success of many of these innovative compounds across classes. If we're talking about GLP-1, it's important that, we anticipate that you are going to have gastrointestinal symptoms in the first few weeks of onset. Or if we're talking about, the PPARs or lanifibranor, for example, could be in the potential 8% of people that might gain a little weight, but that may come at a trade-off for improved glycemic control and dyslipidemia and the potential for an anti-NASH and an anti-fibrotic signal. I mean, when you frame things like that, or even, the FXRs, yes, we anticipate you will itch, and this is how we're going to deal with that proactively. I think as we learn about the side effect, the risk-benefit profile, we ourselves are going to be instrumental in the success of helping our patients, serving the population at risk, and helping propel drug discovery forward, because we'll be better grounded in what we're doing and how we're doing it as we move things forward.
Yes, and I think we even go deeper to some of the work that Louise and Ian are doing in the non-invasive diagnostics and teaching patients in the moment what those results mean. Because if you take the example of prednisone, for example, no patient likes to take prednisone. Almost all of us gain weight. We get moon face. It's horrible, but it works and we can feel it. And our ability to function is often transformed and our symptoms snap back within 24, 48 hours for some of us. And so we understand, okay, I'll put up with a weight gain because I feel and see these effects that I understand. But we need to make sure that for some of these effects that are going on inside in terms of lipid control and reduction of cardiovascular risk or resolution of NASH or things that are more subtle, and that unless we give people a picture of their improvement or give them, numbers to reinforce putting up with some of the side effects, I would anticipate adherence issues and people just saying it's not worth it, when in fact it may be, but we have to make sure that we're pulling it through and we're showing them the effects that things are having.
I think it's a fascinating discussion, and like most people, I was struck by what Vlad and Mary and Rinella had to say, but having listened to the discussion that's gone on, standard of care is difficult to define, but it's not difficult to define, because most standard of care is you've got fatty liver disease, you need to go and lose weight, you need to exercise more, I'll see you in a couple of years. So actually, there's your standard of care. Now, we only need those patients at the beginning, the middle, and the end, because they're left to their own devices. But should now, when we redefine these clinical trials, have a managed program, not dissimilar to the healthy liver, where we manage patients' physical exercise and offer that. Because I think as we move on into the real world and NCDs as a result of NAFLD and NASH, we need to have medication that is proven a higher efficacy than the best that we can offer in the health and lifestyle promotion, because we are exposing them to medication, as you've just discussed beautifully, with side effects that require more medication. So I personally would not want to take medication that is worse than my best non-medicated option, but we don't see it in trials. So maybe that has to be an option now. And I listened to a debate with the Obesity Society, and they were discussing the various diet options. It didn't matter what diet you chose as long as you lost weight. So it's what's best for the individual that works. So that might be standard care, do it yourself, go off and we'll see you. It might be part of a managed program, rather like healthy liver that we were discussing last week. But I do think drugs should show that they're more efficacious and can hit the endpoints greater than health and lifestyle. And I think with more clinical trials that use health and lifestyle, the evidence becomes stronger. When I discuss with the patient, actually it's clinically proven that a healthy lifestyle option against this drug is actually almost as good, but this drug is better. So you give that additional confidence because it's been proven. But you also give people confidence that lifestyle is achievable. And they can see it and they can get that feedback. So I think we do have to redesign trials. But I have to say, I think we do have to be realistic. Standard of care is fairly standard to most people. And then we add something on top.
When Bob Gish stood up to ask about his weight loss contract, which is, basically a sort of a standardized weight reduction intervention plan, I do think that it really is incumbent upon us to be testing what type of lifestyle interventions do work and testing them against each other, whether it's, by analyzing what has been done in different trials or setting out to have an intervention stage or lead in. But I think it is incumbent upon us to be able to give more direction and structure to what standard of care should look like. And having just, come off of Obesity Care Week and having successful introduction and movement in that legislation, I think of all the pieces and supports that patients would need to be successful that may have been missing in the past in their unsuccessful efforts. I think in addition to our intense study of medications, we do need to do as intense a study of what lifestyle intervention actually means for patients with fatty liver disease and NASH. Is it the same as what was in the diabetes prevention program? Is it different? What does that mean? I think that does as much or more service to the larger population of NAFLD and NASH patients than just solving the medication issue. Because even when someone's on a medication, it's going to be lifestyle plus whatever drug regimen. It's not going to be an either or.
First of all, I think those are great points. I'm listening to this in part as a non-health professional who gets treated by physicians who do not do clinical, well, now it's not the case, but for the longest time, who did not do clinical trials and who just treated patients. And some of the phenomena that you witness when you do that are different, okay? So a drug becomes a punishment. You need to do this, do diet and exercise. If you don't do that, I'm putting you on a drug. That's a problem in two ways, right? Which is some patients say, well, what the heck? I want the drug anyway. Why should I bother with diet and exercise? And then other patients start therapy seeing the drug as a punishment because they're inadequate in other ways. Which one of those two scenarios do you like better? Me, I'll pick between them. They both stink. One of the things I'm thinking about in practical terms is that one of the places that took me was maybe trials should be 2x2s. Louise is right. Every patient has their own standard of care. But also Mike's point was right this morning. If we can't normalize in some way, shape, or form non-pharmacologic behavior during a pharmacologic trial, we don't really have much of a way to get away from variability. Ian, it might be just the readers, but I'd be surprised if that was all of it. I think that's a big piece of it, but I do believe this is probably also a piece of it, particularly if it's completely unmanaged. I wonder what would happen if you ran a trial as a 2x2, right? You've got patient lives their life and goes on a drug. You've got patient non-pharmacologically improves. You've got patient lives their life and doesn't go on a drug. And you've got patient pharmacologically improves and go on a drug. Figure out what your total benefit is and how much of your benefit is in which part of the equation. And then when the doctor goes to the patient, assuming we can educate physicians, it doesn't become do this or you go to a drug. It's if you can do this, here's what it gets you. If you do this and then I have to put you on medication, here's what else it's going to get you. If you can't do this, I can put you straight on a drug, but by the way, you'd probably do just about as well doing this other thing or not. But I think on that, among other levels, I think it's a more complex picture than we paint right now. I don't know how anybody else feels about that. You are the professionals. You treat people. But from this side, it feels that way.
Well, let's throw a little curveball in because we've been talking about baseball and bringing to the points that Donna and Ian were making about non-invasive technology. Let's put non-invasive technology up as an arm to motivate and to see how patients respond to management with non-invasive technology. I know, and one of the reasons that I did Towers and Health is I change 9 out of every 10 people that I see, certainly in the interim. The ability I now have is to see them more regularly. And the ability I have is to track that change, that reduction in liver fat. And very few of the people that I have seen so far, obviously COVID has closed a lot of that option down, I have not seen one person go away and increase their liver fat. But I don't mind whether you use ELF or you use something that reinforces regularly enough somebody's behaviour. It is an option that is non-pharmacological, so that you take out the ones that don't need the pharmacology, the ones who will motivate that way, but it has less side effects. The other advantage that has, whether it's FibroScan, whether it's any of these technologies, we're sitting here in a Western society with a lot of access to money. The majority of people that are affected around the world come from low and middle income countries, and it is way cheaper in Bangladesh for lifestyle intervention than it is to put somebody on metformin. And we're not just battling NAFLD and NASH for ourselves. We're trying to get data out of these studies that we can use in the real world that have less access. And if we can't bring studies together that provide solutions to those who are less fortunate than ourselves, then we really need to rewrite the study protocols, because what we put in today can help a lot more people, but we've got to do it in the right way, and it's got to be inclusive of those who can't afford to do that.
So I think that takes us to a very interesting place. So at the end of the session today, there was a discussion about safety and size of trials. And the trials that we do are typically quite small, much smaller than the trials that identified a role for statins for the prevention of death and coronary heart disease, for instance. What makes liver disease so special? Why can we get away with smaller studies? It seems to be because we've selected surrogate endpoints, and those surrogate endpoints may or may not be well correlated with clinical outcomes. So if Roger wants to do a big study of 2x2 study, that's going to require a lot of patients. That's not going to be feasible by liver biopsy, and I don't think industry are really going to be that interested in that study, and it's an academic study. But what if you do a study where you enter people who are at significant risk of progressive liver disease, so they've got high ELF or high FibroScan, you randomise them? That gets away from all of the issues about the conversion rate from screening to trial entry, because most of the people you screen will probably be able to enter then. So that will reduce costs, make it more simple. You'll get biomarker information longitudinally through the trial. You'll get information about whether your drug works, because you'll have a big study, and so although the event rate might be quite low, you'll still see events accruing, and that gets us away from a lot of the concerns that we've talked about.
Ian, I couldn't agree more with this comment, because when you take a look at the statin trials in cardiovascular disease, or even the anti-glycemic studies in diabetes, these are huge studies. In reality, I think the need for a liver biopsy to define disease activity has held us back, because if we have otherwise a safe, well-tolerated therapeutic for the study of NASH, we could potentially model what we've done. You put patients on it, you got an open access approach, you follow surrogate markers of systemic inflammation, lipids, glycemic control or otherwise, and you follow patients to an outcome. We still yet, at least I am still yet not convinced fully, given the insensitivity of the endpoints, that a marginal change from an F3-4 that becomes F3 or F4 is even meaningless, given the variability of interpretation or the sampling. And maybe one of the feasibility hurdles we need to overcome is forgoing a biopsy. And if there is a very promising, safe therapeutic that can be utilized over a longer duration of time, that has a very promising cardiometabolic profile, following patients to a meaningful outcome. And ultimately, that's what's going to matter anyway.
So as a guy with a background in policy and statistics, let me just two thoughts. First of all, Ian, the cholesterol trial got funded by the U.S. government, and the U.S. government's not about to drop $150 million on a speculative 10-year study again. It just isn't how this government works these days. That money all got ripped out in a couple of tax cuts, and it's not coming back so quickly, particularly in the era of the pandemic, unless Biden can get it into the next relief bill, which I hope we will not need to have at that scale, but we'll see. Or certainly less likely to invest in a $150 million study than they would have been 30 years ago. And by the way, it wouldn't cost $150 million now either. The second thought is that the statistics of everything we're talking about this morning drive trials larger and larger and larger. And I think about my pharmaceutical clients back in the day, not in liver disease. And what they would have tried to do was to bite off a piece where they could get an easy indication, get to market, and then worry about it. I think Maru suggested that this morning. Someone, I think it was Maru, suggested that as a strategy this morning. And I wonder why we're not doing that here. I mean, when you think about it, if NASH from F3 to F4, F2 to F3, and F1 to F2, and F0 to F1 are all logarithmically different in and of themselves, then why wouldn't you pick one transition point to go first, for example? Or why wouldn't you think about a different way of defining the differences? Because the broader we shoot, the more we start pushing into these trials, that we're going to have a hard time getting people to fund.
But, Roger, I think Mike Charlton made an exceptional point this morning. I mean, we got a disease that affects 30 million Americans that are at risk for disease progression. And we need some really loud, table banging patient advocates to draw some serious attention to really a national epidemic here of chronic liver disease in the future. We made it happen for HIV. We've made it happen for hepatitis C. We have fabulous patient advocates, Donna being one of them here, but we really need momentum. We need volume. We need more people at the table drawing broader legislation and an infusion of resources into what is now not only a national health crisis, but a global one. We're not seeing that yet.
Is that because not enough people have been tested? If you went round a whole area and fibroscanned 10,000 people, you'd start to hear banging of the drums.
We did have a simple hep C antibody or an HIV antibody, and we are developing algorithms that will empower primary care physicians to case find easier. So all of this is moving in parallel, but it has to move in parallel with not only the therapeutic front, but the biomarker development front, the easier diagnostic approaches to cherry picking those at risk, and the major voice that can be heard with legislators or those that have governmental powers to infuse the same amount of resources into liver disease as we saw with cardiovascular disease.
Yeah, Don, I was going to ask you where the Larry Kramer of liver disease comes from.
I've been known to bang a table. I think, it's interesting, since GLI's, launched a Pediatric and Rare Liver Diseases Council, and the level of patient engagement and partnership with the rare disease community is very different than that of common diseases overall. If you look at, across advocacy, when you take the learnings of what catalyzed or catapulted breast cancer into a new stratosphere, and I've had conversations with Ambassador Brinker, it started Susan G. Komen for her sister, or what, changed the focus in HIV. There are different models. There were different levers that they pull. The HIV community was very much chain ourselves to FDA. We're dying very, and being very upfront. They also had their sort of Elizabeth Taylor moment, as I call it, with being embraced by celebrities and normalizing it and humanizing, HIV. The breast cancer and the overall cancer model was one more of private philanthropy and sort of a lot of inside Washington earmarking and legislation, as you discussed, in the creation of the National Cancer Institute and different initiatives, and then layer on a large grassroots development and some nice non-pharma corporate branding. So as a student of social health movements and activism, it is liver patients, because I think primarily because of the stigma of having liver diseases, have been more reluctant to step forward. The fact that I drive a hepatic burgundy car with liver lady license plates is rare to advertise that I have a liver disease. As we reach out to celebrities and policymakers and others to elevate the issue of liver health overall, I think NASH does provide the best opportunity, and even a better opportunity than hepatitis C did, to position this as a public health and an effort and initiative and priority, and to engage the support, as we have seen in our NASH Council with endocrinology and sports medicine, and as we reach out to the World Diabetes Foundation and others. I see it as picking up the pace, but we are taking the lessons of our hepatitis C, our HIV, our breast cancer, and other colleagues as we move forward. I would note that there have been organizations that have been around for 30, 40 years, and we're still dealing with the public that doesn't know where their liver is. So in the short 6 years that, GLI has been founded, particularly because there was not loud enough advocacy, I think we've made progress. And so I look forward to everyone's participation in International NASH Day, making a louder noise and implementing the U.S. NASH Action Plan, which we had to do because the National Academies of Medicine, couldn't be brought in to act. So we're filling a very large gap, but there is is, I feel, a lot of momentum from the conversations that I have. But I look forward to everyone's partnership to making them more visible.
Can I just ask on that point, do you think the fact that India has now put NAFLD and NASH into their national policies as the first country to do that, and has linked it to the recognition that it is a causative factor to a lot of their NCD issues, will that help and start to drive more recognition?
We are going to make sure it does. We are able to use it as an example of, and as a model for other nations to rise to that level. Everybody has talked for so long about, well, you need to approve a drug to have this investment or movement or cause or visibility. And certainly in India, with that approval, did come this movement. But I don't think we can wait for that in the rest of the world, because we need to be identifying patients and linking them to care across the spectrum of fatty liver disease and NASH. And so we do hope and are working very closely with physicians and grassroots organizations in India to use them as a model and to move everyone forward based on that.
So an hour into this conversation, we should start to think about wrapping up. I don't want to wrap up immediately, but I do want to ask if there's anything that people heard discussed this morning that hasn't found its way into this conversation that you think we need to share or talk about.
Well, the only thing I'm going to say is that all of the drugs that were discussed were actually quite exciting. The whole premise of listening to the to and fro's of the medication discussions, some were more positive than others, but I actually found it very encouraging that we're certainly heading in that direction of getting multi-action medication, side effects or not, that do offer hope and solutions for those in biggest need, hopefully in the nearer future.
The other thing that I thought came out of Vlad's presentation about trials that hadn't succeeded in non-cirrhotic disease was talking about the divergence between the interim endpoint of fibrosis improvement and the endpoint that will drive events, which is progression in fibrosis. And it's interesting that those endpoints are sort of not discordant, but are almost opposite. And we saw a bit of data presented today about progression, both for SEMA, showing reductions in progression with treatment versus placebo, but also a bit for efruxifermin, and it's a very small data set, but it suggests that there is significant reduction in progression, perhaps not as much as one might like to see. Phil Newsom referred to the tenofovir registration studies where they did biopsies after a year and after 5 years, and interestingly, there was no placebo arm in that study. In the treated patients, about 20% of them improved fibrosis at 1 year, which is very similar to our placebo response rate. You might ask yourself why that is, but the treatment with tenofovir abrogated liver injury and it abrogated disease progression. There was only one or two patients in that study that progressed at 1 year, showing that a drug that is very effective at switching off injury can prevent progression. And the efruxifermin data suggested that if you compare it to the other sort of control data, progression was reduced by about 50%, which for a drug that looks extremely impactful on liver injury is an interesting start. And it'll be interesting to see where that takes us from a sort of overall efficacy perspective as time goes on.
So Manal, that reminds me of your observation right after the FDA webcast that one of the things FDA had said was that maybe non-progression was in fact an endpoint in the context of SEMA.
Absolutely. Non-progression is going to be an endpoint. The absence of progression to cirrhosis or any of its downstream endpoints. We've historically been somewhat fixated on regression, but it speaks to the fact that stability and lack of progression is going to be just as important, if not more important, than regression. I am completely content with having a cirrhotic patient stay stable for a decade and never decompensate.
I think that is a point that a lot of people out throughout the field would agree I have banged the table about. I would just like to say that today you can't see it on the podcast, but I'm wearing my Harvard Winthrop House sweatshirt, and I am perfectly willing to trade that out if Vlad would like to create Wildling Mouse t-shirts, because I'd love to wear that. That's
I love
new
that.
hashtag.
I love that. Well, we will have Vlad with us Monday night for the wrap-up, Donna, and you will be there as well, so you can share that thought with him at that point in time, see if you guys can get a business going.
Maybe I'll go print something up.
My only thought at the end of all this, I said this on a podcast a few times, we named the business hepdynamics because we thought this disease was a lot more dynamic than what I was hearing said about it. And if anything, the appreciation of the dynamism of the disease has grown immensely over the last year, but so is the understanding that there's more dynamism to understand. I just think it's a fascinating space. I do, Donna, and this is not in the conversation, but was in this dialogue, Larry Kramer had to destigmatize AIDS for people who with HIV before he could effectively achieve what he did. So I'm wondering if we don't have to destigmatize liver. Don't worry about whether it was alcohol or fatty diets or whatever. You solve the problem. If you're reformed if you stop doing whatever you were doing and the problem exists, where's the stigma? By the way, even if you're doing, maybe there's no stigma, but how do we destigmatize the disease so people who want to go be Larry Kramer? You're destigmatized because of where your problem came from, but not everybody else.
Well, our approach has always been, at the Global Liver Institute about liver health even more than liver disease. And it's, specifically why I don't often, lead with what type of liver disease I had. It shouldn't matter whether it was an autoimmune disease or viral disease or NASH. It shouldn't matter. And I think the liver community has been very fragmented in my, analysis and estimation before GLI. And I think that as we come together with one voice and talk about overall liver health in the same way that people do about heart health or brain health, we stand a lot better chance of being recognized and being a force and creating momentum. So I position things as, if you have a liver, usually wait a beat for everybody to stop and realize that's everyone, except for those of us mid-transplant perhaps, you are at a risk of a liver disease. So this issue applies to everyone, and we need to take up a banner in the same way.
Okay, so first of all, I think that's a great note to close on. I do have a closing question. It'll be different because we're asking closing questions 4 times in the next 2 days, and this is the easiest one to figure out. For each of you, what in the rest of the meeting are you looking forward to most? Brave one, go first.
I'm really looking forward to this upcoming afternoon session on the concept of platform trials. Rethink maybe how we do trial and trial design in this space.
Manal just nicked my phrase. I was looking forward to that one too.
I'm looking for the NASH and forward to the NASH and diabetes discussions.
And me too. It's like the it's all like sheep gathering together. But for me, I think that'll be really interesting given the discussions we've had about available treatments and how it might be best used in practice.
Yeah, I think that's the one I've been looking forward to most since the meeting started, although I have to admit the issue of needing to redesign for broader patient populations and different goals is also fabulous. So I just kind of figure we're all going to be drinking out of the same fire hose for the next day and a half, and we will reconvene as a group 3 more times at the end of each session to figure out what's going on, the we being Louise and Donna and me, and we'll be fortunate to have a whole bunch of esteemed people joining us. Ian, I think, will be back once more. Manal will enjoy the meeting and the slopes and whatever else Deer Valley has to offer her because she is fortunate enough to be there. After session 2, we'll come back first thing tomorrow morning. We will have Stephen Harrison with us. We'll have Naeem Al-Khoury with us, and I believe we'll have Jorn Schattenberg with us, although that's not 100% certain yet. Until then, everybody enjoy session 2. Stay safe, surf on, and thanks to everyone who's been here. Thanks to all the people who've been on this podcast. Thanks to Mike Wilson, who's going to take the next 6 hours making sense out of this, and to Ian Rounds, who's going to make sure everybody knows what we're doing, and to Buzzsprout for making it so easy to do everything we do, and to everyone who listens. Have a great afternoon. Enjoy session 2. We'll see you in the morning. Bye-bye now.
You've been listening to the Surfing the NASH Tsunami coverage of NASH-TAG 2021. Have any questions for the surfers? You can post them on the Surfing the NASH Tsunami discussion group on LinkedIn or Facebook, or send them to questions@surfingnash.com, and we will attempt to answer before the end of our NASH-TG coverage. Thanks for listening. See you tomorrow on the Surfing the NASH Tsunami coverage of NASH-TAG 2021.